Okay. Well, with that, I would like to say welcome and thank you for taking time out of your day today to attend and participate in this webinar. It's the first in a two-part series that's focused on the opportunities and challenges with post-acute stroke and really how a system of principal illness navigation can generate positive outcomes for stroke survivors and the systems that are involved in their acute intervention. Before we get started, there are a few housekeeping items. All the participants will be muted. We will have time to answer questions at the end of the presentation. I'd encourage you to submit those questions in the Q&A feature in Zoom and preferably not chat. We're going to be recording the webinar today and we'll make it available to the attendees and registrants after the event. Our second webinar, which is going to expand on the topics that we addressed today, is going to take place on April 18th. It'll be at the same 11 o'clock Pacific start time. And if you've registered for today's session, you're automatically registered for the 18th. No need to go through that process again. I'm Clayton Duncan, and I'm the commercial lead for Kandu. I'm joined today by Kirsten Carroll, our CEO, Dr. Tudor Joven, the chairman and chief of neurology at the Cooper Neurological Institute in Camden, New Jersey, Karen Seagraves, who, after serving as a stroke bedside nurse, has served as an executive leader for multiple neuroscience programs, and then Lauren Sheehan, our senior clinical director of Kandu Health, who's going to walk us through some of the nuances of our program. Kirsten's going to be kicking us off today with a review of the landscape of stroke beyond the acute event. She'll be followed by Dr. Joven and Karen. They will provide their perspectives from the chairman's seat and from the hospital administration perspective, respectively. And then finally, as I mentioned before, Lauren's going to lead us through our approach at Kandu and talk about some of the outcomes. So with that, Kirsten, I will turn it over to you.
Thank you so much, Clayton, and thank you so much to all of our attendees, both who are live with us and who are catching this in the recording. Incredibly grateful. Again, we know everybody working in stroke care is so busy, and your time is incredibly valuable. So thank you for joining us today. So if we can jump to the next slide, we'll start with a review of sort of the purpose of Kandu and what drove us to develop this program. The very first statistic that you see here is really the devastating statistic that our mission is built around, which is that, and this came out of the AVERT trial, they showed that a year after stroke, 28% of survivors rated their quality of life as poor or worse than death. The average stroke survivor lives over 10 years. That's a very long time. And I think we believe dogmatically that we can do so much better than this. So the optimism for us is that none of this has to be this way. We can dramatically improve quality of life and outcomes for stroke survivors. There certainly needs to be an economic logic in addition to sort of this purpose to drive this as a business. And this is where we really drove in deep to what is the post-acute healthcare spend on stroke? How is this impacting healthcare systems? Stroke is the single most expensive diagnostic history a person can have. And what you see is that in aggregate, just in the United States, we already see $25 billion a year spent just on the first year of post-acute care after stroke. And the leading driver of this is not actually from skilled nursing or rehabilitation. The largest driver of cost is from inpatient readmissions. You can see here it's almost 1 in 4 patients at 90 days, and it's about half of patients at 1 year. And readmissions in stroke are multifactorial, and Lauren's going to talk a lot about this later and how we get involved in improving this. But the lens of stroke requires understanding post-stroke impairments. And when you combine those post-stroke impairments with the underlying conditions, you have a really complex issue to navigate. So if we go to the next slide, we've done some of our own original research. This is looking at over 265,000 patients of Medicare claims data longitudinally. And what we see here is a lot of the causes of readmission after stroke. And from left to right, you start at day 0 and you go all the way out to day 365. And if we bring up the first highlight, you'll see the contribution of recurrent stroke and TIA. And this is really where so much of the post-acute care is focused. Blood pressure control, medication reconciliation, making sure that we avoid another stroke. The risk of that happening really starts to plateau at 30 days. So if you get through that the first 30 days post-discharge, which is typically that period of time hospitals are held accountable for, we're feeling really good. But if we go to the next highlight, what you'll see is that the thing that continues to grow so much more dramatically is these infections and sepsis. And this isn't just a medical issue. A lot of stroke survivors are learning to navigate life entirely new with a transformed brain, a transformed body, things like bathing, toileting, mouth care, skin care. They have to learn all over again. And when they aren't supported in this and they aren't taught and they're managing these complex psychosocial issues, oftentimes that leads to UTIs, pneumonia, skin infections that can progress to sepsis. So we felt like there was so much more we could do to support patients as they return to community settings, not just improve their quality of life, but also reduce these readmissions. Now, our program focuses on people right now returning to community settings. And so the next question is this the population where you can make an impact? So if we go to the next slide, we can look in the claims data at patients for whom there's an NIH stroke score recorded. On the left here, you see the least severe strokes. On the right, you see the most severe strokes. And what we find is even patients who have a relatively mild stroke, an NIH stroke score of 0 to 5, have nearly a 25% readmission rate at 90 days. So this is not just a problem of the most severe strokes, and it's often these patients who are perceived to be doing well, who maybe have more invisible deficits, who are overlooked. They're not considered complex, they don't get as aggressive follow-up, and they certainly don't get as much as support and rehabilitation. So Kandu aims to address this. The really exciting thing for us, if we go to the next slide, is that we felt like if we developed a new model of care to address some of the voids in the care for stroke patients, if we could prove that we were demonstrating both better modified Rankin scores and better readmission scores, that there would be a way to make a sustainable care delivery model for this. And then we were very, very grateful that CMS actually stepped forward ahead of us, thanks to their work in cancer care, to establish a new code called Principal Illness Navigation. So if we go to the next slide, we'll take a look at what Principal Navigation is. This is a code that applies to any Medicare patient. It's a CPT code who has a serious condition expected to last at least 3 months that puts them at a high risk of rehospitalization, nursing home care, or death. So this concept of principal illness navigation is well established in cancer care, but CMS was actually forward thinking enough to realize it's not just cancer patients who need this. So stroke qualifies for this condition. The work we do one-on-one with the patients, with the care partners, as well as the care coordination, all count as principal illness navigation. Starting January 1st, this was covered under Medicare Part B. It is an outpatient service. It requires an E&M visit with a prescription in order to deliver, and it allows us to provide this guidance, navigation, and support. So if we go to the next slide, the core elements, right? And if we think about how does this compare to nursing navigations or chronic care management, this is what principal illness navigation is supposed to look like by the CMS rules. You start with a person-centered assessment. Can we contextualize somebody's recovery plan and what needs to happen for them in the context of their lived experience, their living conditions, their social determinants of health, their own goals? You're expected to provide supportive services, care coordination, health education, but also the goal is for them not to be dependent on this care forever. So building patient self-advocacy tools, teaching them to navigate systems themselves, facilitating behavioral change, and actually building community support so that they have other people with lived experience to lean on. This is actually particularly important in addiction medicine and behavioral health, where they can actually bring in peer support advisors as well. In really exciting development for us, all of these were elements of what we developed in our care model. A huge thank you to the teams at Cooper University and Cedars-Sinai who have worked with us for years now to develop and validate that this is working. And so it really allows us to step forward and attempt to be the industry leader, bringing this to stroke and demonstrating how valuable these services are in stroke as a population health issue. So we're going to go to the next slide. And I'm happy to introduce Dr. Tudor Joven, Chief Medical Officer of Kandu Health, Chairman and Chief of Neurology at Cooper University. Tudor, if you could provide your perspective first on the needs of the patients you work with, and then sort of as a chairman of a program, how you think about where we go in stroke. And for those of you who don't know Tudor, I don't know if anybody in the world has done more to advance stroke care and establish evidence that established best practice than Tudor. And just so incredibly excited to have him here with us. Thank you.
Thank you. Thank you, Kirsten, and thank you to everybody for participating. We're very excited to see such great attendance. A bit about my background. I'm a bit in an atypical position to be speaking here because I'm, so to speak, a plumber. For the big part of my career, I have been sort of focused on the interventional treatment of stroke. People who would come in with blocked vessels in the brain, who would open them up. It's been quite a struggle because these treatments were not proven to be effective and not covered and so on and so forth. So a good chunk of my career I've been dedicating to prove that these treatments are highly effective. And I was blessed to be, as I say, at the right place at the right time, and was lucky to be part of some landmark trials that have proven and have changed practice. And nowadays, thrombectomy is considered the standard of care for stroke treatment. But as I was sort of in the thick of it, and as I saw this treatment being elevated to standard of care from completely unknown, it dawned on me that we're just addressing a very minor part of the journey of a patient who experiences a stroke. And in addition to that, the ones who undergo thrombectomy are the worst of the worst. But as Kirsten showed, as in a sea of stroke patients out there, most of the patients don't have a large vessel occlusion. And for them, stroke is, could be equally devastating. Even though the large vessel occlusion patients have the worst outcomes, we know that stroke patients, most of them don't return back to normal, even when they have what we call a good outcome. And this comes from, and for the ones who still believe that these rankings of the ranking scale is an accurate description of how patients do after stroke, and that the ranking 0-2 is a good outcome, which is something that we kind of in the interventional world, we have accepted as a truism. It's very clear if you actually look at the life of these patients who have quote unquote good outcomes, their outcomes are actually not that good. If you have a ranking of 2, you're independent in activities of daily living, but you're not back to work. You're not doing a lot of things that you enjoyed and did before. There's a lot of mental health, brain health issues. And that applies to ranking 1 or even ranking 0. There's a lot of symptoms that are not captured by these scales by which we measure outcomes. And as I became more focused on these, less glamorous but equally important parts of stroke care, I realized that there's a huge need out there to address the needs of patients of all types, any kind of patients, not only large vessel occlusion, following discharge. And that, in fact, I started sort of paying a bit more attention to my patients from that standpoint and realized that they're kind of lost. Most of the patients are after discharge. Stroke is a condition by definition where the brain is impaired, and many of the patients don't remember what they had, what symptoms they had, why they had it, what's the best treatment to prevent. and how they adapt to a life after stroke, and that there's huge opportunities. Just like I felt there are huge opportunities to make people better on the front end of the stroke admission by opening up their occluded vessels. I realized that we need to dedicate at least as much efforts and resources to working on the back end, that there's a huge aspect of post-discharge care that we're not addressing. And that a company like Kandu, we were lucky to kind of cross paths with Kirsten, and I sort of immediately signed on to the concept. From any standpoint, from any standpoints, I knew from my own experience, and now that I'm paying more attention to this, it's even clearer that there's a huge gap in care from when the patients are discharged to when and if they kind of get back to society the same way they were before. And most of the stroke victims are not going to be the same. But efforts to make them get as close to being the same as possible are definitely warranted. And that's what Kandu is about. It's about improving quality of life of patients who had a stroke. And as I embarked on this journey, it became even more clear to me how inadequate the current systems of care are to address these gaps. Fortunately, with stroke hospital and systems of care certification processes, quality emphasis, patient experience emphasis, sort of these more patient-centric approaches, I can see that we are making some progress as a stroke community, as a medical community, in terms of crediting and giving due credit to this side of stroke care. Not only because it's not only because it's effective, but it's also cost effective, and it helps patients. And now we have these capitation models, for instance, where things like readmissions and bundled care models. Quality of care is a major component because it saves dollars and it makes patients better. And this is what Kandu is sort of driving now. We know that efficient post-acute care, the kind of stuff that Kirsten was mentioning, preventing infection, making sure that patients take their medications, they're on the right medications, they go to their doctor's appointments, things that we as physicians perhaps take for granted, but they're definitely not guaranteed, and they make a difference. So, that's kind of what I learned by being part of this process. And that also mental health and the psychological impact of having a stroke is enormous, and it's completely unaddressed in our current models of care. So I became more and more, convinced that Kandu is doing the right thing and is making a positive impact. And then in addition to that, I think because they're always a question of not only is this effective, but is it cost effective? Does it add to the costs of the hospital? Are we saving dollars? Because you need to make the case to hospital administrations as well. And I think that there's so much cost that is incurred by inefficient post-stroke care that one can also make a very strong argument that more attention to post-stroke care reduces healthcare costs. And I think we have now data from our own patients to show that. So, overall, I feel very lucky to be part of this group. And you're gonna hear now from Karen from an administrator standpoint as well, and how what the system level problems can occur from inefficient or inadequate stroke care post-discharge.
Thank you, Dr. Joven. And I'm Karen Seagraves, and I'm actually going to talk to you about the perspective of the hospital administrator, the perspective of the bedside clinical nurse caring for stroke patients, and then also from the perspective of the patient and family. I often get asked, what is my biggest concern as an administrator? And I hear this a lot of times from stroke coordinators as well, when they're seeking to find ways to champion Kandu to their leadership. And the teaser, we're going to talk about that in our next webinar, but just some detail right now. The goals of a hospital administrator, and regardless if you're the CNO, the CMO, the CEO, are the same. Usually there are pillars, and actually this slide aligns it in pillars. Predominantly finance. And when I say finance, does not mean we're all looking to make a buck. It means that I need to be able to treat the next patient that comes into this hospital, and I need to be able to pay the individuals who care for the patients. Patient satisfaction is also of utmost importance. And I don't just mean how they fill out their surveys, but it means the experience for a patient and their family gave them the tools and resources they need to get well when they transition back to the community. And are they going to come back to us for care because of the experience that they had when they were here? And a patient or a family who had a bad experience may also impact the reputation of the hospital. Quality is of utmost importance as well. And like Kirsten mentioned early on, stroke patients just don't get readmitted for stroke alone. Things like sepsis and UTI, and while those are of utmost concern when they're in the hospital, they continue to be problems or have opportunities to become problems in the outpatient setting. Throughput is something that became apparent during the pandemic that we didn't do well in acute care. And even with that behind us, we are seeing higher volumes than ever in hospital, and being able to move a patient to the correct level of care, to do it quickly, and to make sure we make room for that next patient is a focus. Innovation is something that I get excited about as an administrator because I know I have problems. And looking at data, looking at quality metrics tells me where there are opportunities, but people can introduce things like Kandu that may be a solution for a problem that I have. And lastly, retention. People who care for stroke patients endure a lot of stress because they cannot provide the kind of care that they are used to providing, that they are trained to provide, and that our patients and their families need. So those individuals, and I'm going to speak specifically to nursing, encounter many frustrations in their management of stroke patients because, first of all, there are a number of disciplines that manage stroke patients in the hospital. They might see neurology, neurointerventional surgery, neurosurgery, neurocritical care, all of the different rehabilitative therapies, and that's complex in and of itself. But figuring out what they're supposed to do next, when that information is everywhere, it might be embedded in the chart, there's not an opportunity or time to be able to coordinate well. And time constraints not only prevent that coordination, but they prevent the ability to teach a patient and family vital skills or to give them resources to manage symptoms or to manage navigating the healthcare system when they leave, or even to know who to call if there is a problem. And so there are gaps in the patient and family resources and experience in stroke care in the US today. Psychosocial needs, and Dr. Jobin, you mentioned this, many of these patients will experience depression, anxiety, fatigue, stress, and if we're not giving them the tools and resources to even recognize those things, how are they supposed to manage those? And lastly, we get very frustrated in healthcare that people don't show up for their follow-up appointment, but there are many breaks and cracks in the processes, so they don't even know they have an appointment, or they can't get in touch with someone to get the appointment, or even to know who they're supposed to follow up with. From the experience of the patient and family, I was fortunate enough to have spent many years facilitating stroke support groups for patients and their families. And these are things I heard time and again. Number one, that we didn't prepare them for before they left the acute setting. And number two, that were common among all stroke survivors. First of all, cognitive challenge. And these might not be permanent deficits, but they've had an insult to their brain and they've been hospitalized. And we expect them to retain vast amounts of information that we've provided to them. Memory and cognitive issues make that almost impossible in the immediate post-acute setting. And also the ability to communicate may be impaired. Even in the absence of aphasia, although we know many patients have expressive or receptive aphasia, it's still difficult to say what it is they're feeling or what these changes in how they perceive themselves or their experiences, to put a name to it. And that's frustrating. We mentioned the psychosocial symptoms already, but what about the loss of independence? Stroke patients did not plan to have a stroke. And the sudden inability to perhaps provide for their family, to drive their car, to bathe themselves can cause frustration, but also embarrassment, depression, and feelings of guilt. Navigating the healthcare system. At best, it's difficult for people who don't have all of these challenges. It is challenging to find out who you're supposed to call, to get a call back, where you're supposed to go, when you have an appointment, when do you resume a medication, are you taking the right medication? So that is a challenge that I have heard consistently that our stroke survivors and their families face. The last thing I'll touch on, but actually Lauren Sheehan is going to address in more detail in the next section of our presentation, are social determinants of health. And this means that when a patient's in the hospital, we may not have the time or the resources or the ability to make sure that they can even afford the medication we're prescribing them, or that they can get to the appointments that are necessary for their follow-up, or that they have a home environment that's safe. So I'm going to pass over to Lauren, who is our Senior Director of Clinical Services for Kandu, and she's going to go into more detail about how Kandu helps navigate these issues.
Thank you. Thank you, Karen, and good afternoon. So glad that you could join us, and thank you for taking the time today to learn more about our program. I'm Lauren Sheehan, occupational therapist by background, and I oversee our navigator team and our clinical programming. And I'm excited to tell you more about how we've created a post-stroke recovery trajectory for folks that from many of my co-presenters you've heard and have experienced yourself slip through these cracks in post-acute care. So who is Kandu? Kandu is a tech-enabled healthcare service company providing remote navigator-led support to stroke survivors and care partners after hospital discharge. And we do this by providing education, guidance, and resource support, as well as community support groups through a dedicated clinical navigator, an easy-to-use app. Overall, it is our goal to empower, support, and connect those affected by and treating stroke, which includes you. And we see ourselves really as an extension of the hospital team into the community. There are really two elements of the Kandu program that we'll talk about more in depth. One is our clinical navigator. This is a dedicated support person, an occupational therapist or licensed clinical social worker with stroke experience who support the survivor and care partner as well as a multidisciplinary team that's in the background, which we'll talk a little bit more about. Along with that, we've created a digital platform, or the Kandu app. And this was co-created by stroke survivors, really to be accessible to those with a variety of post-stroke impairments. So going into more detail on both of these components, as Kristen mentioned, our team supports the survivor through post-acute principal illness navigation. This starts with an initiating visit with a provider, Nancy Tsai, our medical director, who's a physiatrist, looking at the course of a survivor's stroke care and treatment, gathering that past medical history, social history, and really qualifying a patient for principal illness navigation. They then are passed to building a relationship with our clinical navigation team. And this one-on-one relationship, again, between the survivor and care partner, and the care partner is an important component of this as well. The survivor, and if they have a care partner, have shared access in the app. So they're learning together, supporting each other, and supporting the recovery process. Our jumping off point as a navigation team is really the discharge summary that comes from our partner hospitals. We work to understand, what are the follow-up recommendations and resources that the patient already has available. And then how do we help them prioritize next steps? As you imagine, and as you've experienced with your own patients, there's so much to do in that post-acute recovery period. And just sifting through what to do when is really a big part of our early support of patients. Our navigator team also does a social determinants of health screening. This helps us to understand potential barriers to recovery, things that might get in the way of the recovery process. This includes helping navigate their own healthcare ecosystem, who to go to whom for what and at what time points, and then really preparing for those appointments. So it's not just making sure that someone gets established with a PCP or a neurologist in follow-up, maybe has additional workup that needs to happen, but that they really understand the importance of those visits, who they're seeing, and what questions to ask so that they can be in the driver's seat of their care. We do work to normalize mental health and the support that survivors need to go through post-stroke recovery and adjustment. As Karen mentioned, and is not news to you, post-stroke depression occurs quite frequently at about 30%, and that's probably underreported. We work to normalize the experience of mental health challenges and to support patients through the appropriate triage plans. Not surprising to us, we planned for this as we developed our Kandu programming, but about 8% of the survivors we've served have experienced suicidal ideation. We have a multidisciplinary team to support patients in crisis and to get them to the appropriate level of care, to safety plan and ensure that they have what they need to be successful. In terms of the app or platform, there are three main components. The first is Learn. Our extended team has developed over 600 unique articles with the goal to deliver the right information at the right time. Kirsten mentioned earlier all of the potential opportunities for infection, which can turn to sepsis. Our early education is really on staying safe at home, what to watch for, home safety, ensuring that the environment is set up appropriately, managing impairments, and then that really evolves to identity. Who am I now after the stroke, and how do I get back to things that are important to me? We've co-created this content with over 10 disciplines of medicine and importantly, our survivor and care partner community as well. The learning is connected to accomplished tools in the app to really make that learning actionable. What do I do now with what I've learned? This links to things like questions to ask the provider, symptom trackers to manage and watch things like triggers for post-stroke fatigue. And all of these are two-way streets of communication in the app between the survivor, their care partner, if they have one, as well as the navigator. And then an important component of our program as well is the Connect component. We have on our team Kandu ambassadors who are stroke survivors and care partners themselves with lived experience, and survivors and care partners that we serve can connect in the app asynchronously, as well as on our live virtual support groups. And our navigator team members are not alone. We are really supported by and surrounded by other disciplines in this multidisciplinary team approach. Physiatry, as I mentioned, our medical director is a physiatrist, neuropsychology and psychology to bring in that holistic mental health support. We also have in-house dietitian and neurooptometry consultants, as we've found that those can be challenging folks to find for stroke survivors post-discharge. And we see, of course, our Kandu ambassadors as part of our broader team as well. We are proud of the outcomes we've generated as part of the Kandu program. On the next slide, we'll talk through, this is a poster that was presented at ISC this year, of our early enrollees. And I believe you'll receive a link to this poster as part of your participation in the webinar today. We'll dive into some of the components in more detail, but we do hope that you read a little bit more about our outcomes from our first graduates. Before we dig into more specific outcome information, I really want to highlight who the Kandu program is intended for. We created the program for folks, as Kirsten mentioned, who are discharging home. So that's about 60% of stroke patients discharging home or eventually home in the first 30 days post-acute event. What this looks like in terms of our relationship with hospital partners, about 50% of patients that are referred enroll. We're continuing to look at ways to increase that, but that's quite good if you're familiar at all with digital health, compared to what's typically seen, which is low single digits or low double digits from referral to enrollment. We're excited to see that once we enroll a survivor or their family member, that folks stick with the program. They see the value enough to participate with us to completion. We have a graduation rate of over 90%. And based on that navigator relationship, our navigation team is able to collect the modified Rankin scale scores for 90 days at over 90%. And these are reflected back to our hospital partners as well. What does principal illness navigation really look like more broadly? This isn't, a couple of phone calls that the team makes to check in on survivors and families, but it really is a relationship to understand those barriers to recovery, roles and goals, and to support survivors through that recovery process. The average number of touch points that our navigators have with survivors is close to 10 over an average of about 11 weeks. So for those first 3 months, we're very involved in that post-acute follow-up and supporting the success of survivors to the tune of about 6 hours per navigator survivor relationship. So that's one-on-one time with the navigator. An additional 2 hours are spent by our team on average coordinating care, coordinating community resources, and curating content. And then one of the beautiful things about digital health is that we also get to see what patients are doing when they're not directly involved with our navigator team. And we're seeing enrollees spend over 4 hours of additional self-directed time in the app. That could be reading articles or listening to articles, messaging, or participating in the Connect groups. Go ahead. And it's important to look at who we've served really as a cross-section of the post-stroke population. We've been fortunate to serve individuals across the lifespan, really. Adults from the age of 26 to, I know we recently had an enrollee that was 92 years old. So this is now 27 to 92. And throughout the spectrum of enrollment MRS. As Tudor mentioned, even some of those rank-in zeros can still really have challenges that may not be visible. We've served primarily MRS 1 through 4, and we've seen some folks in the MRS 5 category as well. So really well positioned to serve people across the spectrum of stroke presentation, as well as across payers. We've served individuals throughout the payer landscape, Medicare, Medicaid, commercial plans, as well as those that are uninsured. And importantly to us, we've also served 60% of the survivors that have come through our Kandu program are non-white. We know that individuals who are in this demographic are statistically more likely to slip through cracks in the healthcare system. And it's important for us to utilize Kandu as a way to improve access and health equity. I mentioned earlier the social determinants of health screening that our team does to understand potential barriers to recovery. This is a really important part of our practice, as these social determinants can be quite dynamic and change throughout the discharge process and the weeks and months following a stroke. For example, if an individual was previously employed, has a stroke, returns home and is unable to go back to work, that completely changes their social needs landscape. Other unmet health-related social needs like unstable housing or food insecurity both increase the risk of developing chronic conditions and reduce an individual's ability to manage those chronic conditions. You can see as we've assessed for social determinants of health, mental health does top the list in our survivor cohort, followed by financial strain and some of the other elements you see here. And these are complex patients. Over 25% of our enrollees aren't just dealing with 1 or 2 social determinants of health, but 5 or more social determinants. So really have potentially the cards stacked against them in terms of barriers to recovery. And over 70% of enrollees have at least one health-related social need. Importantly, we're looking at access of survivors beyond Kandu and to healthcare outside of the work that we do. We've been able to support 15% of the survivors we've served in applying for new primary or secondary insurance. And for some, this means coming from being uninsured to insured, which opens up a whole nother world of healthcare support. And one of the tenets that we believe at Kandu is that quality of life impacts health. We really believe these outcomes are based on the relationships developed between the navigator, survivor, and care partner. And as we look at some of the reported outcomes, we see things like 98% self-reported medication compliance. Our navigator team has been able to connect individuals 90% of the time to neurology follow-up and established a patient with a care provider for primary care at 95% if they didn't have a previous relationship. We see all of this lead to what we hope and think are improved outcomes. Our readmission rates for our Kandu patients are at 4.5% all cause for 30 days and 9.5% for 90 days, which are about half of the published ranges. And I wanted to give an opportunity for one of our early graduates, Tony, to tell his own story. It's really part of our mission at Kandu to elevate the voice of stroke survivors. Tony was one of our early graduates. He was 33 years old at the time of his stroke, uninsured and on emergency Medicaid. He likely would have qualified for inpatient rehab, but unfortunately was not able to find a placement that accepted his insurance. So he went home with his care partner. And Tony had a variety of different social determinants of health that could have been barriers to recovery. We were able to support him first to get his basic needs met, which he'll talk about. We connected him with PCP and neurology care through a federally qualified health clinic. We were able to connect Tony with and support him in applying for grant-funded outpatient therapy for rehabilitation, and ultimately supported him in requesting accommodations to return to work. So we'll have Tony talk about what participating in the Kandu program meant for his recovery.
I feel a lot more in control when, especially coming off the stroke, when there's somebody there to guide you and help you. You know, it's kind of like take me by the hand and guide me, please, because I don't know what just happened to my brain. I was more scared about being able to find a doctor that was going to help me afterwards. That was just the biggest fear. It's like, I need help, but I don't know where to begin. So it was like getting the right doctor and whatnot and making sure that they were giving me the information needed. The biggest worries were, am I going to have enough for medication? Am I going to have enough for therapy? Am I going to need any medical equipment? Am I going to have to rearrange stuff around the house? Being able to get resources, even as something as simple as just getting food, was very, very helpful, because it was one thing I didn't have to worry about, which let me focus on what was important, which was my recovery. Now that it's been a year, my recovery keeps going forward. It keeps progressing. Thanks to Kandu, thanks to the care of my navigator. It's joyful. It's a sense of fulfillment and accomplishment. I don't know what recovery would have looked like without this help. I don't want to imagine it.
Thank you. And we look forward to continued conversations with you and your teams about how we can support survivors you serve.
Thanks, Lauren. I appreciate that, and I always appreciate hearing from our survivors. Tony is amazing, and just really thankful that we can have that impact. There are a few questions that I think that we'd like to address. The first one, one of the questions is, we have a high percentage of non-English speaking stroke patients, about a quarter. Do you have the ability to translate to non-English speaking patients? Lauren, I'll let you address that.
Yes, thank you. Very important, of course, for access to care. We started in English. We are working hard in the background to translate our educational content, which, as you can imagine, 600 articles, into Spanish, and bringing on Spanish-speaking navigators. So that will be our first or our next step in really expanding access to non-English speaking patients. We are also looking at translator services to come into these phone calls and video calls for languages that maybe are a little less common outside of English and Spanish. So definitely on our radar, Spanish will be first here, and we will be ready to support Spanish-speaking survivors in the coming months. So just a couple of months away.
All right, great. Thank you. Next question, are there any restrictions as to who can be enrolled in the Kandu program? I think the question behind the question there is, for what patient types and perhaps payer types is this appropriate? And maybe clinical types as well. Kirsten, I think I'll let you address that question.
Yeah, sure thing. So our intent is to be as accessible as possible. So we do not turn away care to anybody based on their ability to pay. So we are taking ownership of our need to develop the infrastructure and systems to deliver care to everybody. And in the meantime, we will deliver care to everybody. It also makes it much easier for the discharging team to not have to think through that Sudoku chart of coverage and who can qualify for the program. Right now, the model of care, as Lauren has said, is for people who are returning to community settings. So discharge to home or inpatient rehab. In most places, that's about 60% of the discharge volume. And then we will, in time, extend our services to skilled nursing populations. It's a different model of care. And so giving Lauren and the clinicians time to build that appropriately. It also is different from principal illness navigation because they are inpatient at a SNF. And so figuring out the right model of care and the right way to bring that to patients. And then, of course, on the question of languages, that one ties together. Is we were originally English only. We will very soon be Spanish capable. We've already navigated a few Spanish speaking patients and finding other creative solutions to be able to serve all languages.
An additional question. So this one says, my hospital already has a nurse navigator in place. How is Kandu different from that program? Lauren, Karen, I will let you tag team this answer.
Thanks, Clayton. Karen, do you want to kick us off just with some background on nursing navigation, and I can fill in the gaps?
Sure. Yeah, I think that I've encountered a number of programs that have navigation, and the biggest frustration of the navigators in these programs is that they can only get to a limited number of the patients that they serve. So if you have one navigator and you discharge 1,000 patients a year, the focus is really on just trying to keep up. And it's impossible to provide exactly what we discussed earlier in terms of the depth and the breadth of your navigation. And also for many, that navigation stops after the 1 week post-discharge phone call, or maybe after a month max, or it's very limited to trying to get a 90-day modified Rankin scale score. We work with the navigators to help them and to augment the work that they do and to add to the work outside the hospital that benefits the patient and makes life, I would say, easier for the inpatient hospital navigators working in stroke.
Yeah, great. The only thing that I would add to that is just the kind of wraparound of this multidisciplinary team. We have multiple kind of practice lenses, and so we're able to manage some of the psychosocial pieces, which we mentioned, really triage some of those crisis situations, know the landscape of community resources really well. And the time spent, I think, is a big differentiator between the time directly navigating and doing the resource and coordination. That's 8 hours per individual that we serve. So it takes time to develop those relationships. So exactly to Karen's point, we can extend and sort of augment the programming that already exists.
Yeah, great. Thanks. A couple of additional questions. How does Kandu address hypertension and any blood pressure specific interventions? Do you work with the local primary care providers and care teams, or mainly provide educational information?
That's a really good question. With the addition of principal illness navigation and that E&M visit, the patient will see a physician on our team. So we can and will coordinate with local PCPs to address that. One of the big things that I didn't mention in terms of our team's additional training and approaches is really from a health coaching or motivational interviewing standpoint. And motivational interviewing is actually one of the interventions that has seen promise in management of hypertension. And so looking at survivor risk factors, supporting both the tools, so we make sure that folks have a blood pressure cuff, they're able to utilize it given their impairments. We can work with them on those things. They can log blood pressure with some of the tools that we have provided, and we work with them on the ancillary pieces. So yes, definitely providing education, ensuring that they know what their parameters are to be within range, right, within safe range. Definitely empowering the survivor to work with their PCP on management, and then managing some of the other components that lead to hypertension, diet, exercise, those health behavior change components that take time.
Yeah. Thanks, Lauren. Last question I think that we have time for, and then we'll adjourn, is how do we support folks that have poor tech abilities that might be challenged by some of the technology that's out there? Kirsten, I think I'd like to hear from you on this, and then Lauren, if there's any context around that would be great. And then we'll adjourn.
Yeah, and this is a multi-part answer, right? And so even if they had high-tech abilities before the stroke, things may have changed, whether it's hemianopia, hemiparesis, aphasia. So it's been an absolute pleasure to co-design this platform with stroke survivors with the full rainbow of effects of stroke. So that's a start. A next step is for people who did not have tech capability, having robust education and training around tech. We are so often teaching them how to use their phones, not just for our own program, but I need to scan paperwork today or I'm going to not get my disability benefits at my job. Can you help me do that? Three-way calling, right? I have aphasia and I need to advocate for something. Can the navigator do a three-way call with my insurance company to talk about this? So there's nothing more delightful than an octogenarian finally getting on a Zoom for the first time with a support group and lighting up with pride that they have figured out how to do this. And then there are some people for whom that is not a possibility. And so we always meet people where they are. We have a number of patients who have not either had phones or not been able to activate the app. And for those, it is good old-fashioned telephone calls. Sometimes we do direct mail, email, text. There are, of course, restrictions around privacy, security, and what you send through which venues. So everything is designed with that in mind. I am so proud of the extent to which this team goes above and beyond to engage with the stroke survivors and makes it happen and gets them what they need. I'd say the other thing, sometimes it's technical problems and sometimes it's the memory and attention deficits, struggling with no-shows and remembering visits. And, one of the first things Tony said was, wow, this team understood it may not be a good time and I may need to reschedule. And that just set me at ease. So yes, all of that.
Great. Last question, just rolling in. Do we provide physical therapy? So Lauren, if you'd like to answer that in the context of our approach, I think that would be great.
Yeah, great question. We do not currently provide physical therapy. We're setting up the infrastructure so that someday we could, if we decided to go that route. Today, our approach really has been to partner with groups that are doing this well. For example, sort of one of our relationships for post-acute support of our patients with aphasia has been through a group called Expressible, who provide remote SLP, speech and language services. So we do not, our infrastructure would allow us to, but our focus really is primarily on principal illness navigation.
And Lauren, yeah, I think I should add there, we didn't talk through how we're structured. So this is practicing medicine. Kandu is actually 3 companies, Kandu Health and 2 professional corporations. The professional corporations are independently owned by Dr. Nancy Tsai, who has supervisory oversight as a physiatrist. And so Occasionally, there are resource poor areas. There are people who don't have insurance coverage. We do have the capability for Dr. Tsai to do a specialty physiatry consult remotely. I think our OTs do incredible work with patients who have not gotten what they need from OT and maybe need home exercises or adaptations. We will continually consider what is already well served in the community and what do we need to further build out in our own PCs to support this population. And we are open to feedback from all of our clinical partners in what they would like to see us add if there are certain resources needs in their communities. And we can explore that.
Yeah, great. So thank you. Definitely want to respect your time. We really appreciate you spending the time with us today. Know that that indicates that you're just interested in this post-acute system of care and focused on how to improve the lives of these stroke survivors as they transition home. We strive to make that evaluation super easy. We try to use system-specific data, and we really like to partner with the clinicians to build that business case. Our next webinar, it's going to be the 18th. I mentioned that. We're going to dive into the impacts, how the program fits within your system of care, greater detail on telling that story to the administrative side of the house to generate stakeholder alignment and consensus. So thank you. And if you can't wait until that time, and we'd appreciate it if you reached out to either Shane or myself, we'd love to walk you through it. But thanks again, and we'll see you on April 18th. Have a great day.